we have in store for you today. One of our newest business partners, Primary Diagnostics, is here to talk to us about the Bennett Polypharmacy profile, and that is something that we think is going to be a real game changer when it comes to med adherence, and a really innovative thing that we're very excited about. So with that, I'm going to go on ahead and turn this over to Brian Bibb with Primary Diagnostics, who's going to be introducing Dr. Bennett, who will be presenting the webinar for you today.
Okay. Thank you, Laura. Thanks everybody for attending today. We really appreciate you taking the time to join us and taking time out of your busy day. Thanks to Flacco's and to Laura, Nicole, and everybody for helping set this up. We're really excited to become new business partners recently with Flacco's, and I respect for everybody's time, and I'm sure tight schedules. I will just go ahead and let Dr. Bennett get started. Thank you.
Okay, thank you very much, Brian, and thanks again, Laura, for arranging this, as well as to Nicole, who we met last week for the first time as the president of Flacco's. But we think we have an exotic here for Medicare patients that I think you'll find very interesting, that does not exist in the marketplace. And to give you a little background about myself, start here. I'm a private practice physician. I'm board certified in family medicine by the American Board of Family Medicine. I'm also on the board of the Georgia Academy of Family Medicine, as well as a member of the membership commission for the American Academy of Family Medicine, representing about 120,000 family physicians nationwide. I'm the former Associate Dean of Medical Education at Washington Venice University. I went to Morehouse School of Medicine, did my residency there, where I served as chief resident, and was also a member of the Morehouse School of Medicine Board of Trustees. And currently I'm adjunct associate professor of family medicine at Morehouse, and every once in a while I get to teach a few residents primary care. I've done a lot of international things as well. This is me in London at St. George's University. It is the second oldest medical school in the UK, founded in 1732. The founder of the polio vaccine went to St. George's, as well as the Gray's Anatomy that we actually read actually was founded there at St. George's. And what they asked me to do was put together a U.S. clinical program for them that they've never done before in the United States, and I was pretty much the lead clinician putting that together. I've done a picture in Saudi Arabia with the U.S. attaché to the U.S. Embassy in Saudi Arabia, from Saudi Arabia, Dr. Alice Say. This was also a picture with the president and chairman of the board of Washington Adventist Hospital and University. Basically, my role here was facilitating medical students and medical residencies residents who needed to come to the United States to study clinical medicine. It was my responsibility to link them with various hospitals in the United States. And I was fortunate enough to work with the U.S. Embassy in Saudi Arabia as well on this. Here locally, this is down there. As we know, there's a tremendous physician shortage over the last 10 to 20 years, projected to continue for another 10 years. And I was actually one of the original founders of Xavier University School of Medicine down in Aruba. And I'm happy to say that, over the last 10 years, Xavier has graduated hundreds of students as MDs, and a significant numbers are actually practicing medicine here in the United States. Back to home, this is what I do 2 days a week. I'm still a clinical physician. This is my oldest patient. We call her Miss Nettie. She's 102 years old. So, it's always great to practice clinical medicine. And I've done, mission work, as well as a child in India that I've actually worked with. And that's the benefit of me being family medicine, and why I love family medicine. It gives me an opportunity to take care of people from prenatal care to pediatrics all the way through to geriatrics. But while we're here today, let's look at some numbers. From a statistical standpoint, 29% of patients take 5 or more medications daily. Our adverse drug events cause about 700,000 emergency room visits annually. About 100,000 people die each year due to adverse drug events. It's the 4th leading cause of death in the United States, and it costs the U.S. taxpayer about $3.5 billion in additional spending because of these additional adverse drug events. What are the current procedures we use to reconcile medications? Because that's really where the rubber meets the road. We can refer to the chart or the electronic health record, but this list many times is incomplete and does not reflect the medications other doctors may be prescribing. We can ask the patient to write down from memory the medications, but this again is incomplete and has recall error issues. Have the patients bring in their medicines, which is what we usually do. This is time consuming and still subjective. And this was really the start of why I wanted to create this profile. About 2 years ago, a toxicology rep came into my office, wanted me to start using a tox panel and all my patients, including my seniors, and I told them that's crazy, that's ridiculous. There's no reason for me to use a regular tox panel on patients. What I need is a primary care panel that actually covered all the medications I use in primary care, and he told me it didn't exist. So I decided to actually look it up. I was able to partner with a couple laboratories, and after about a year, we're able to come up with the Bennett Polypharmacy profile, which I'll go over shortly. We can also get a report from the pharmacy, but again, the pharmacies only know what medications are picked up or not picked up from their pharmacy, not if the patient's going to a different pharmacy. That's going to be a problem. And then if you look at the use of software developed for medication reconciliation, they use various data points and metrics again, but again, this data is only as good as the data collected. Bad data in equals bad data out. I'm going to show you where EHR has some issues when it comes to medication reconciliation as well. The Bennett Polypharmacy profile is a unique urinalysis for the most common drugs prescribed by physicians. It is just a urinalysis. There's no blood involved. It's a very easy, quick test. It's the only test available in the United States that actually screens patients for blood pressure medications, cholesterol meds, cardiac, over-the-counter pain meds, herbal meds, and supplements, migraine medications. This is actually the panel itself, the Bennett Polypharmacy profile. And if you look at the panel itself, look at these sections: blood pressure, amlodipine, calcium channel blocker, atenolol beta blocker, clonidine and alpha blocker, diltiazem, calcium channel blocker, HCTZ, a diuretic, ACE inhibitor, losartan, and ARB. It goes on and on. The most commonly prescribed medications and blood pressure are screened here. From a cardiovascular standpoint, used for patients post-heart attack, post-stroke, DVT, atrial fibrillation is also available for screening. And you know, those patients are high risk. So anyone who's on clopidogrel or Plavix is someone you need to know is taking or is not taking their medication. A patient with congestive heart failure, digoxin is here as well to screen them for digoxin. Patients who are taking Coumadin or warfarin as well can be screened. From a cardiovascular standpoint, here from Lipitor to Zocor, Crestor, Mevacor, as well as niacin that's used to lower cholesterol triglycerides. The chronic pain meds are similar to what you would get on there's nothing extra there, but at the bottom here you have all the major classes of the generic covered, the most common drugs prescribed. The way I came up with this list, I looked at the $4 Walmart list, and over the last 15 years for me practicing medicine, I came up with the drugs that really are about 80% of everything that we prescribe. Migraine medications are here, muscle relaxants, and Bennett here. Acetaminophen, these are all omeprazole, pseudoephedrine. These are all over-the-counter medications that can have dramatic effects on our patients and other medications. We have ginkgo, niacin, and red yeast rice. I'm going to discuss those a little bit later. Our recreational drugs are there. The psychiatric drugs are there, which are very important from a psychiatric standpoint. Now that we're spending so much attention these days, paying attention to things like mental health, we have to look at things like bipolar stress syndrome, schizophrenia. This panel actually screens for the most common drugs prescribed for those disease entities, sleep medications, and a lot of our seniors suffer from anxiety or depression, and all your major SSRIs and various types of antidepressants and anxiolytics are available here, as well as weight loss phentermine. So this is the most comprehensive objective screening tool available in the United States for screening, especially seniors, for issues of polypharmacy. What do the results look like? I want to bring up 4 different examples to show you how easy this is and how important the results section is. Here we have a patient, a female born in 1938, which puts her at about 78 years old. She's taking amprazolam probably for anxiety. And these are actual really patients. We've redacted the information about them. She's taking amlodipine as well as atenolol, hydrochlorothiazide. She's diabetic because she's taking glipizide, and she's also taking metformin. The green section here tells us which medications is the patient taking that actually is showing a positive in her system. Metformin she's taking, hydrochlorothiazide she's taking, lisinopril she's taking. So that's great. It covers some of the diabetics, and lisinopril which helps to cover the kidneys. But down here you can see that she's not taking her glipizide, and she's not taking her atenolol, which again are red flags. So the only reason she should be on this glipizide would be that her blood sugar is not controlled. She needs the addition of this sulfonylurea, and she's not taking it. So that's something we'd want to kind of make sure we discuss with the patient. And obviously the patient should be on her amlodipine. If she has a history of high blood pressure, she should be on amlodipine as well. And this is telling us she's not taking the amlodipine. The bottom section where it says inconsistent positive results are patients who are where medications show up, but they were not prescribed by the original physician. So in this case, there were no additional medications that showed up that were not prescribed by this physician. Another example here, this is actually a younger person. This is a male born in 1971, 45 years old. The reason I bring this up, you see, according to the medications prescribed, this patient is supposed to be on atorvastatin or lovastatin, as well as simvastatin and Zocor. Now, obviously, there's an error here somewhere. There's no way in the world the physician would prescribe 2 statins for this patient. Patient's also supposed to be taking multiple blood pressure medications, carvedilol, clonidine, enalapril, furosemide, hydrochlorothiazide. So obviously a very difficult to control hypertensive, and there's obviously some issue when it comes to the statins. According to these results, the patient is taking their atorvastatin or Lipitor, so that's consistent with what they're supposed to be taking, but they're not taking, I've highlighted here, their simvastatin. Now this may mean that this patient was originally on simvastatin and they were told to stop it and switch to atorvastatin, but the EMR was not updated, and so both medications still appear in the EMR. It could be a situation where it could be a multi-specialty or multi-provider clinic, and that the patient saw one provider one visit and another provider the other visit, and did not see the other medication that was there. So again, here's an opportunity where our panel actually corrects the EMR. And as I said before, with all the software that's available, the data in is only as good as the data presented at the end is only as good as the person who put the information in to begin with. At the bottom here are inconsistent positive results. So they're taking over-the-counter ibuprofen, and that's something we would note in the chart. Just do a couple more quickly. This is a 71-year-old female. We're looking at her results here. She's supposed to be on atorvastatin for cholesterol, clopidogrel, which again is Plavix, Cymbalta for her depression. If we look at in the panel here, we see she is taking her metoprolol, which was one of the medications that were there. Her gabapentin is fine. But look at this section, inconsistent negative. These are medications that the patient was prescribed, but she's obviously not taking. They're coming back negative. So she's not taking her antidepressants, which we know is a problem. More importantly, she's not taking her Plavix, which again, stroke, DVT. That could be a patient looking for another event that would be a high-risk patient that you'd want to definitely identify as high risk and pay closer attention to. And she's not taking her cholesterol medication, her atorvastatin. So obviously, this is a 71-year-old patient that should be taking her statin tablets, and she's not taking it, and will require closer monitoring. And finally, this is a patient, 80-year-old male patient who's supposed to be taking a slew of medications. Section here, the patient is taking absolutely nothing. So this again will be clearly a higher risk patient and someone that we would want to bring back to the office and discuss. Did they not pick up their medications? Is there a problem with getting the medications from the pharmacy? What is going on here? But this patient is taking literally nothing prescribed to them. All right. So, I wanted to relate this to something we're very familiar with. There was a time when computers used different operating systems depending on the manufacturer, and the DOS or disk operating system platform standardized operating systems across manufacturing lines. So what this meant that DOS was the platform operating in the background of all software to follow. You could not run a basic operating system in the background. And that's the way we see the Bennett Polypharmacy profile of BPP, which is trademarked and a patent to the U.S. Patent Office. It is a platform by which all medication reconciliation software or data has to be confirmed by our test because it's the measurement you have out there. And finally, any medication compliance or reconciliation data that does not use our test is limited at best. So I'm sure right now many ACO for their data and data points that they use to try and decipher the issue of medication compliance, non-compliance reconciliation, objective tool to verify any of that software. Where our Bennett objective tool you can use. Eliminate most patient confusion on what they're taking or not taking. Objective documentation of medications prescribed that a patient is compliant or the patient is not compliant. It protects the physician from potential litigation. We know for us as physicians that one of the things that is a very hot area of litigation is verification of what you prescribed and what the patient was taking and was not taking. This would not be an objective record in the chart for the physician to protect them against malpractice litigation. It protects seniors from polypharmacy error. It allows better management and facilitates better communication with our patients. This is not an I got you test like toxicology where it's okay, you're not taking your Lortab or you're taking something else or using marijuana, I'm going to kick you out of my practice. The main purpose of this is to facilitate better communication with our seniors to make sure they're taking what they're supposed to be taking. That's why this test exists. It decreases the risk of adverse events due to polypharmacy, and overall it's going to decrease healthcare costs due to morbidity and mortality. It's going to decrease hospitalizations, et cetera, due to polypharmacy or medication misuse. Now, what is the relevant data of the U.S. population? About 42.3 million seniors are in the United States. 92% of these seniors see their doctor, so we know the seniors are going in regularly to see their physician. Nearly 1/3 of Americans between 57 and 80 every day. 68% of Americans are taking over-the-counter medications. And with all this, we recommend that the BPP be screened or tested for anywhere from 2 times a year to 4 times a year. Now, how do we come up with that data? Well, seniors usually go and see their specialist once or twice a year. So we want to make sure we're catching those seniors whenever they go and see their specialist to make sure that any changes that took place we have objectively documented. Also, we find that at least once or twice between that time, there's some discrepancies that we want to, again, do another test to make sure the patient is compliant, especially if we change the patient's medication. This is a way of screening maybe 1 month after medication change to ensure the patient is taking the medication. For patients who are taking 7, 8 medications, you might want to screen them 3 or 4 times a year just because of the quantity of medication that they're taking. So that varies. Now, what are we finding so far? We've done tens of thousands of screens so far, and about 80% of screens are coming back inconsistent with what was prescribed in the regimen. And the question is why? Well, EMR are charting on the medication list is huge. Our screens are coming back inconsistent, not because the patient is not taking what it's supposed to be taking, but because they did it properly, and our test actually. There are times when, again, specialists change the medications, and me as a primary care physician, no one tells me anything. I never get the report, and the patient can't remember. And when I run this test is when the patient remembers, okay, that's right, I saw cardiology, and they put me on metoprolol. I'll give you a quick story. There was a patient I had that came in. She was about 80 years old. It was a Friday evening. And she wasn't feeling well. She was having some slight chest pain. I did an EKG. It was completely normal. But I said, something, you don't look well, Miss Thomas. And I told her husband to take her to the emergency room. She went to the emergency room, and she was having a dissecting aortic aneurysm. Within 2 hours, she was on the operating table, and the aneurysm was repaired. She followed up with cardiology, who put her on metoprolol, and which slows down your heart rate. It's a beta blocker. And about a month after that, she followed up with me. But when I saw her, her pulse was about 52. Her normal pulse in my office is about 70. And I asked her, did you have any other medications? She said no. I ran a polypharmacy screen, the BPP, on her, and she came back positive for the metoprolol. And I said, Mrs. Thomas, are you taking metoprolol? And she said, oh, yeah, that's right. I forgot. My doctor, my cardiologist put me on it when I got out of surgery. So these are examples, again, of cases where patients, especially seniors, may not remember everything, and this screening tool gives us an opportunity to have a conversation with them about it. Our patients get to refill that. They take over-the-counter pain meds that we don't have on our list. How many times do we ask our patients if they're taking naproxen, or they're taking ibuprofen, or taking Tylenol? Rarely in the office, even though we should, do we ask them about that to test for that. And many times patients are taking herbal medications that again, we just don't ask enough questions about use, about discontinuing their medications. I've had one particular patient that was on 3 different statins, one prescribed by me and one started by her cardiologist. Between all of that, she had 3 bottles of statins in her purse. So again, it helped by what is going on. And then when we ran the test, she came back positive for those 3 statins. So that was a very, very dangerous situation. Let's look at the herbal medications and why they're important to test for. Warfarin is used very commonly for atrial fibrillation, for deep vein thrombosis, et cetera, but sometimes older patients may start using ginkgo as a memory tool. Well, ginkgo as well as aspirin is a blood thinner, just like warfarin. And if the patient is taking ginkgo and aspirin at the same time they're taking the warfarin, and then they're on and off the ginkgo, their INR can go up and go down as they abruptly start and stop the ginkgo. And here we are adjusting their warfarin every single month because we can't get it under control. And the issue isn't the warfarin dose, it's the fact that they're taking ginkgo, we didn't know anything about it. Some patients take over-the-counter niacin, but niacin can lower your blood pressure. So a patient could come into the office who came off their niacin, and all of a sudden their blood pressure is higher than normal, and we're chasing our tail pressure is higher when we knew nothing about the niacin. Red yeast rice. Believe it or not, probably most physicians don't realize that red yeast rice breaks down to lovastatin or Mevacor. And red yeast rice can cause body aches and muscle fatigue, the same as a statin. And you can have patients who are not on a statin coming in and complaining of muscle aches, and it's due to this red yeast rice over-the-counter medication that's, again, covered in the BPP. And some things I mentioned before with ginkgo, bleeding, bruising, unexplained, the patient could be on ginkgo. The BPP was screened for that. Niacin, GI disturbance, flushing, again, BPP screens for that. And red yeast rice, muscle aches, joint pain on a patient that we think are not on a statin, they could be taking red yeast rice, and that's the reason why, because it's breaking down to lovastatin. All right, physician objections. As we know, physicians don't want to do anything you tell them to do. I mean, I'm one of them, so I know exactly what you go through at the ACOs. What are some things they may say? Okay, I don't need that test. Well, my response is current procedures are strictly subjective, and this is the only objective screening test, and also consider risk versus benefit of drug interaction and also decreasing your risk of litigation. I will remember to order the test. Now that's very common because, to be honest with you, this is my test, and I don't remember to order it in my own office at times. So what I do is, and what we do is set up an actual protocol within the office that each physician signs off on, and it says that we will test patients twice a year, that we will retest the patient if there are multiple inconsistencies 30 days later, and that's the protocol that's followed. So the physician doesn't have to remember all the time to order the test, and when the results come back, the physician is notified that the results come back, which takes anywhere from 5 to 7 days to do so. Next, I don't want the patient to pay for the test. The test is covered by expensive test. This year, I believe the reimbursement is somewhere between $250 and $290 for the test, so not very expensive at all, especially if we're doing it twice a year only. Physician may say, I already do urine drug screens. Well, urine drug screens are strictly for drugs of abuse. It is not a primary care panel, which is what our panel is. They may sting. Well, genetics, as we know, only lets you know whether or not the patient actually can metabolize or not metabolize a particular medication. This screening will let you know whether the patient is taking or not taking the medicine, so something completely different. And the final thing, an objection may be, my EMR and pharmacy alerts already checked for this. Again, the EMR is only as good as the person who recorded the data. The pharmacy can only report interactions of drugs that it knows about, and patients who use multiple pharmacies or take over-the-counter pain meds and herbs, there's no way in the world the pharmacy or the EMR is going to be able to record that or pick that up. Okay, coming down to the last few slides. As we know, the Medicare Chronic Care Management Program and annual wellness exams were created to give more attention to our seniors with multiple chronic issues. And this is an excellent place for our polypharmacy profile, that during the annual wellness exam that a BPP is ordered, and we know not only what the wellness exam results are, but the BPP results to see whether or not an intervention needs to take place. For patients who sign up for chronic care management, every few months they can be asked about medication reconciliation and see whether or not they've actually done a recent BPP, and if not, be sent back to the office to get the screening done and then recording it in the EMR for the physician. And one of the services we would provide for the clinicians or for each clinic is a comprehensive preventative polypharmacy management program. Provide is a medical assistant or administrator at the office, if that's something you wanted us to do, that person will collect the urine specimens that would help to manage the chronic care patients as well as the annual wellness exam. As all three, 2 out of 3, 1 out of 3, we're open to any combination of any of those things. And again, we would make sure that the paper, or that when the results come back, that it is actually documented in the EMR and the physician is notified that the results are back. So, this is a very, very exciting product. I've been practicing since 2000, and, I see everyday patients who are just all over the place with their medication, and there was really no way to be able to reconcile their medications properly. And I really appreciate the labs that work with me to get this tool up and running. It is effective. Again, tens of thousands of screens have been run nationally so far in most states, and we're finding that it's a very valuable test, because a test is only as valuable if it changes your management. A test is a complete waste of time if it does not change management, and this test changes management because it forces a conversation between the clinician and the patient. It has the patient have to do something differently, or the clinician have to do something differently, so it makes a tremendous difference. And we believe that this test can keep patients out of the hospital. No repeat trips for congestive heart failure for not taking the medications. No repeat trips for hyperglycemia due to diabetes. No trips to the emergency room for diabetic urgency or emergency because they're not taking their medications, et cetera, et cetera, et cetera. It gives the ACO leadership an opportunity to zero in on the most egregious, if I can use that word, patients when it comes to non-compliance, or the very high-risk patient that you really want to pay a lot of attention to, that it does not create a problem for you when it comes to revenues for the ACO. So with that, I thank you for your attention, and we'll entertain any questions.
Okay, if anybody has any questions, I'm going to go on ahead and enable the audio. You can also type a question in the question portion of your webinar dashboard, or enter something in the okay.
I cannot hear the question.
Okay. Let's see. Okay, one question that we have is, what is the procedure code for billing test to Medicare, and that was by, looks like the asker was Rodney, I believe. Okay, I don't see any questions that have come through yet.
Hello, this is Haiti Rodriguez with Accountable Care Options.
Hi, we can hear you, Haiti.
Great. We did have really two questions, and first of all, it sounds fantastic, especially for an ACO in Florida that deals with the elderly population. We do think it would be beneficial. First of all, how do we initiate the test or acquire the supplies to perform this? And secondly, what is the procedure code, whether it's a CPT or a HCPCS code that is being used to bill Medicare?
Okay, can everyone hear me now?
Yep, we can hear you.
Okay. First, we have Brian Bibb, who's our regional manager, and he'll be more than happy to speak with anyone if you would like to be able to do the BPP or Bennett Polypharmacy profile in any of your practices through your ACOs. So I'm sure that Laura can get you in contact with him. And basically, you'll get a kit from us with basically the cups, urinalysis cups, as well as the requisition forms. It's a straightforward way. The patient comes in, they urinate in the cup, it's packaged and sent to our lab, and within 3 to 7 days, results are sent back. There's a code for chronic multiple medication use, as well as whatever the multiple medical conditions are. So typically, when the requisition is filled out, the codes are first chronic medication use. Second would be hypertension. 3 would be diabetes, and 4 would be high cholesterol. So basically, the additional codes support the initial chronic long-term medical use code. It's always reimbursed. We've had no issues with reimbursements or any kickback from Medicare because of the coding.
What would be the actual procedure code? We understand the diagnoses that would validate the test, but when you're billing Medicare, obviously we have to submit certain codes to get this particular test covered. Do you have that data?
A laboratory. So it's not a billing test that the actual ACO would do or be reimbursed for.
Okay, so basically the payment mechanism will work. We pay you for the kit and to run the test, and you do the Medicare billing. Am I correct?
No, basically, look at it as if you're just doing a UA for a person with urinary tract infection, and you're using LabCorp. You just collect a specimen, and the specimen will be sent to LabCorp, and LabCorp will do the billing. In this case, it will be a patient with multiple medications. You want to see if they're taking it or not. So at the level of the office, a urinalysis will be taken. It will be sent to the lab. The results will be sent back, and the lab does the billing. So there's really no expense at all to the practice or to the ACO.
Okay. And would we receive information as to what states are actively performing and billing Medicare successfully for this service? I'm just concerned that patients may get a bill after the fact in the state of Florida.
Now, for most claims that I know coming out of Florida, maybe they'll get an EOB, but there will be no additional billing coming from the lab for the patient. There's no separate billing for the patient. Whatever Medicare pays is what the lab will accept. Does that answer your question?
Do you currently have clients in Florida?
We have scattered sites from individual physicians. We do not have an ACO grouped site anywhere.
Okay, thank you.
But we have individual physicians throughout the states who are using the test. Now, when it comes to the physicians, one way that they receive additional reimbursement is a model that we show that really the average practice should be able to do about 80 screens a month, or about 20 screens per week, and that boils down to about 4 a day. I mean, I see about 20 patients when I'm in clinic, so 4 out of 20, at least 4 out of 20 are seniors that will qualify for this test. And when you're doing 80 screens per month, I'm able to bill for a urine screen or a 99212 code. So I collect about $20 for each of those. And then out of the 80 patients that I screen, maybe about 20 have multiple inconsistencies that require another office visit the following month. So I get another 20 office visits each month from the screening, 99213 visits for about $70 per visit. So those are ways that the physician can actually benefit from a revenue test. The physician won't benefit directly from the test itself, but definitely just collecting the specimen and actually doing the follow-up could be pretty significant every month.
Are these for the most part Medicare patients?
Actually, it's for any patient taking 4 or more medications. Private insurance or commercial does reimburse for this, but like most other claims, they're kind of all over the place. It's like, whether or not they're reimbursing for the latest DPP4 inhibitor for diabetes. Some reimburse, some don't. So it's a matter of finding out which insurances actually does reimbursement, which ones don't. We find in our office that, in my personal office, that about, I would say 30% of the patients that we're screening are below the age of 65, and about 70% are over 65.
Okay, thank you for that. What about the Medicare patients? You say you're not billing them. Are you balance billing them if they don't have a secondary insurance?
No. I mean, whatever Medicare pays is what is accepted. And I know there's a very sensitive issue when it comes to Medicare patients getting all these bills for tests, et cetera, et cetera. So we're very keen on that. And whatever the rules of engagement are for Medicare is what we're going to follow. But we're not going to chase down any, senior for balance billing.
Got it. Thank you.
Well, let me ask, since you who are executives, how does your current organization deal with medication reconciliation and compliance issues? Okay, well, Laura, I think we're good.
Okay, thank you everybody for your attendance today and for your questions. We will be posting the recording for this webinar on the Flacos website, and feel free as well to send any follow-up questions that you might have. I will be forwarding Brian Bibb's info to everyone so you could follow up with any questions that you might have. And you can also send them to me direct as well, and I'll be sure that they get to the correct person. So thank you so much for your attendance, and everybody have a great day.
Okay,
Thank you.
thank you, Laura. Thank you, everybody.